Thank you for having me. Thanks, Dr. Soriano and Dr. Haleh, for having me here. As an anesthesiologist, I feel like I've infiltrated a secret society. So thank you. I'm happy to be here. And please don't turn on me. I'm here to show you how we can help you and how we can help each other. And if I'm looking a little tired, because I spent the last 4 days practicing poor ergonomics because I'm in the middle of a Disney trip with my kids and I flew here from Orlando this morning. So this is a nice reprieve for me. This is the break. So let's start. So my job today is to talk to you about OR team ergonomics and how it's kind of an all for one for all. And the tips that we've kind of heard are amazing, but we can help each other achieve those tips and achieve those goals. And, I'm an anesthesiologist from the University of Toronto and Sunnybrook as well. I do co-chair the programming committee of the Society of Surgical Ergonomics. So my plug there is please November 1st, join virtually. It's a great conference and you'll learn a lot and it gives you practical tips. So if you take anything away from my talk, I want you to take away that I want you to understand the importance of the team. We know there's a rising cost to healthcare. We know there's an increasing demand for healthcare from patients, and there's a war for talent. Everyone's moving around. All team members are moving around. And what keeps healthcare workers in their job? It's job satisfaction, but also one of the main reasons the literature that are being cited is worker well-being, and ergonomics is a massive part of that. However, 93% of the literature, or 90 to 95% of the literature, it's solely based on specific specialties, whether it be anesthesia, general surgery, orthopedic surgery, or neurosurgery. And further publications need to start taking a step in terms of how teams interact with each other. Because we know that the team doesn't work in silos, right? And but yet we're looking at it individually. So we know that irregularities in workflow occur from a combination of demands, including complex cases, complex pressures to perform and improve efficiencies with demanding priorities. But this can result in increased mental strain, increased mental workload, as well as a physical strain. And we're made to take that, and are we meant to take that on individually, as individual specialties, as individuals in the OR? No, it should be a team thing. So irregularities can also impact our patients as well. Approximately 60% of patients that enter a hospital are going through the ORs, and 30 or 40% of costs when it comes to a hospital budget are pertain to the surgical specialties or in the ORs. And despite this, there's a mass exodus of healthcare workers outside of each individual sites, individual regions. And why is that? And that's because of worker well-being. There's an increased strain, increase of lack of autonomy and disability. So what can we do about that? And how is that important? And what that's showing is that the workers, as well as the healthcare environment, lead to increased efficiencies, and increased well-being leads to increased efficiencies in the ORs. There's a decrease in lost work days. There's an increase in efficiency, reducing costs, and decreased waste of materials and overall hospital image if the workers are happy and feel well. So, because there's a paucity in literature, and this is something that Dr. Haleh kind of mentioned earlier, what we took on was something called SOAR initiative, Simulation for Operating Room Ergonomics. It's a large initiative, it's an international initiative. It goes through 3 phases. Basically, phase 1 is we designed a survey sent out for people to fill, for our nurses, anesthesiologists, and surgeons to complete. And we've been doing qualitative interviews, which are just wrapping up right now. At the same time, we've brought in observations we brought in different specialties to conduct observations for ergonomic assessment. That includes human factor specialists, chiropractors, physiotherapists, who actually come into the OR and watch what we do and look at possible pitfalls as well as things that we're excelling at in order that we can make a simulation curriculum or an educational curriculum for a team to perform well when it comes to ergonomics. So what we did was we generated a survey. I'm not going to go through all the steps of how we generate, but what we actually looked at was awareness and understanding, use of established best practices. We asked about barriers to optimal ergonomics, impact of ergonomics, as well as interdisciplinary interactions. And we found that 90% of those people who completed the survey, we have about 283 people who were eligible for the survey. We got about 53% of a response rate. 90% of them experienced discomfort or pain. And that's in line with the literature. About 40 to 90% people say there's a potential work-related musculoskeletal injuries or they're dealing with pain. They say about 70% of, but what's more striking is that 70% of healthcare workers that have pain are usually due to cervical, lumbar, spine, but 60% of that, they take it home with them and they feel pain outside. And 50% of that stated that pain actually affected their work. Is that a surprise to any of you? Exactly, and it wasn't a surprise to us. So why are we lacking when it comes to ergonomics initiatives? So we asked about barriers, and we found that no one's really taking the lead when it comes to overcoming these barriers, and that's a big issue. And likely they're not taking the lead due to one of two categories, personal or organizational. And in personal, it comes down to number one, a lack of knowledge, and number two, a fear of speaking up. When it comes to the organizational barriers, there's lack of time, there's lack of space that's cited, lack of equipment, or someone taking the lead in terms of lack of leadership, or is it ergonomic guidelines or policies that pertain to all team members? So what we found was, when you're looking at this is results from our survey, purple is nursing, green is surgery, anesthesiology is in blue, black is overall, and it's a score out of 10. And we found that 70% of people have said that they have no ergonomics education whatsoever. Is anyone surprised about that? No, right? And most of that comes from learning on the job. But yet, almost 100% of people said ergonomics is extremely important to the way they function and the way they perform. The second thing is, well, why aren't we taking the lead? It's a fear of speaking up. Barriers to optimal ergonomics. So these are some of the quotes that we got from our qualitative interviews. 62% of people felt a fear of unfavorable perceptions from others. Individual ergonomic adaptations were perceived as a convenience. So if you look at the first quote, someone noted that they were being perceived as difficult for changing positions or set up to be more ergonomic. While someone else mentioned that, something that Dr. Haley had mentioned, that wellness mat or that anti-fatigue mat was an unwieldy personal item of surging convenience. If that's the perception, how are you supposed to move ergonomics ahead? So that kind of leads to what is commonly referred to as cognitive ergonomics as well as physical ergonomics. A lot of the mentions that we've been talking about, a lot of things we've been talking about is physical ergonomics. Now, physical ergonomics is optimizing the physical environment to reduce the risk of musculoskeletal injury and promote comfort and efficiency. That's kind of influenced by workstation layout, equipment design, that type of thing, and mechanics during stress. While cognitive ergonomics is usually forgotten, but extremely important. And it optimizes the mental workload demands to enhance performance and reduce mental workload. It involves factors such as communication, decision-making, information processing, and mental workload management. And there's been studies looking at surrogates of cognitive workload and cognitive ergonomics in surgeons. They've shown that oxygen consumption increases for surgeons. They've shown increased heart rates, significantly increased urinary epinephrine, norepinephrine levels before and during surgery. They've also analyzed heart rate variability. It's reduced during operation, especially with increased workload. Is anyone surprised by that? I wouldn't think so, right? So what can we do to impact both physical and cognitive workload? The first thing that's kind of the endoscopists that are leading the way in are ergonomic timeouts. Has anyone heard of the ergonomic timeout? Thank you. Has anyone employed the ergonomic timeout? Thank you. Well, I urge you, this is an easy first step. Now, the ergonomic timeout, just like any other timeout, can happen at multiple times. So what I would say, these are my recommendations in terms of what should be included in an ergonomic timeout. The first is introductions. If I don't know the name of my team members, how am I going to say, Dr. Hille, is your back hurting? Can I raise that table for you? Dr. Hille, your monitor is going to hit me in the head. Can I please move that? right? It's more difficult. It's easier to stay quiet if you don't know the name of the individuals you're working with, and this is common, right? And we assign, I would say, in that ergonomic timeout, assign a lead. Because there are going to be times when you yourselves as a surgeon, there's going to be complex periods where you might not have the insight or the time or the mental capacity to notice that it's been 3 hours without you moving, where a lead can step up and say, is it time for a break? Ergonomic timeouts can also include timing of breaks or check-ins, whether it be 30 seconds or 60 seconds, or just a check-in where we say at the hourly mark, we speak up and say, how is everyone doing at this time? And this is where anesthesia can speak up, nursing, PSPs, the surgeons speak up. Then you identify potential risks to your ergonomics. There's gonna be times where this period, during this surgery, where I'm gonna be needing the bed height at this point. The nurses might say, I am height challenged, so please let me know where all of your which sutures or which type of equipment that are not in a sterile field, you're gonna need more often, where I can have at a lower point in the OR. Because in our OR, some of our sutures are kept really high. So you need stools just to get up there. And you need repetitive movement. Then the granular equipment, placement and use. Where are we going to put the laparoscopic, the robotic equipment? Where are you going to put the equipment, the monitors, so that I can help my surgical colleagues, my nursing colleagues? The nursing can help me when I'm intubating. The surgeons can help me in terms of placing IV poles or their monitors so that I'm not walking into them, and vice versa. Cables and wires, Dr. Halle mentioned, putting tape down for the cables around the room. So if I know how many cables are going to be, or the nursing team knows where the cables are going to go, we can adapt to that, or my gyroscope, or my fiber optic bronch, and that type of equipment. And then discussion of assistance. If there's specific timings where I need the surgeons, or the surgeons need me, or the nursing team needs me, or the nursing can help mine, I can point that out in the timeout. And then I say a clear statement of ergonomic agreement, cognitive ergonomic agreement. This is where we say there's a psychological safety factor here. Please speak up. We make it clear that ergonomics is valued in the OR, and together as a team, we know each other, and we will speak up, and it's okay during the procedure where we're not going to judge if I ask for that anti-fatigue mat, if I ask for a stool, or I move that height of that bed around. These are some of the survey where the granular best practices where we were reported. This is the actual physical, when it comes to physical ergonomics. The main thing I want you to note from here is that there's a lot of black and yellow where we want more green in there. So when it comes to warm-up exercise, intraoperative breaks for hydration, can I stand up and say to the surgeon, do you need a cup of water, right? Can I provide a cup of water through a straw? Intraoperative breaks for stretches, the anti-fatigue floor mat, repositioning equipment, specialized clothing. From myself, I can adjust the temperature for the people in the room, especially when they're wearing lead or when they're wearing in the OR for quite a long time. Using chairs or seating options, stools, advanced equipment, which Dr. Halle has spoken about. So we've talked about the low reported knowledge and use of ergonomics best practices. I've talked about the team dynamics. Do not prioritize of support optimal ergonomics, and give some solutions to that. What about the leadership? So just to end off, I'm going to talk about the leadership support. And some of the qualitative feedback we got was, comfort carries no weight in the OR. No incentive from leadership to deal with this because we all continue to work anyways as professionals. We basically put our head down and get through it. Not our priority for OR leadership. Does this kind of hit home with everyone? Yep. So am I going to say that I have the answers to you? You could go to your CEO and say this, and they will say, yes, here's $1 million for ergonomics. I don't have the answers to that. I'm sorry. But I can give you to arm you with some ammo, okay? Ergonomics help reduce costs. $1 for every $3 spent on workers' compensation stems from insufficient ergonomic protection. Ergonomics help employee productivity and work quality, 16 to 30%. And ergonomics contribute to a better safety culture. 75% of employees say that personally safe is important to them. So what I would say is align with the strategic priorities. You can fit ergonomics to any strategic priority that you have at your site. I guarantee it. I don't even know your strategic priority, but I guarantee you can fit that in. And that's the first part of the elevator pitch. Next is conduct ergonomic assessments if you can. Get a physio in, get a chiro in. get someone in who can look at it or from different perspectives. I'm talking about team. A team approach is important. If you go to your leadership as the nursing manager, as the manager, as the anesthesia chief, as the surgical chief, it'll have that much more weight together. And continue education in services as a team for when it comes to ergonomics. And don't forget to mention that ROI. Thank you.